Welcome everyone to today's webinar. I am Emma Goodman with Becker's Healthcare. We will begin today's webinar with a presentation and panel discussion, and we'll have time at the end of the hour for an audience question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our panelists. We are thrilled to have Robin Norman, Senior Vice President and Chief Financial Officer from Virginia Hospital Center here today, as well as Michael P. Burke, Senior Vice President and Vice Dean and Chief Financial Officer of NYU Langone Medical Center. Leading our discussion today is Keith Lowcamp, Senior Director, Industry Strategy for Workday. And Keith, I'll now turn the floor over to you to start today's webinar.
Thanks, Emma. I'm excited to be hosting this discussion on the topic of mergers and acquisitions. We have a great panel who will share their experience and perspectives on the subject. Before I introduce the topic and begin the panel discussion, I'm just going to spend a couple minutes introducing Workday for those not familiar with the company. Workday is focused on supporting organizations such as healthcare.
Muted.
Focus. As a result, we have over 1,500 customers, including over 100 healthcare providers, with over 70% that are live. These customers benefit from a 99.9% uptime, and most importantly, the ultimate measure of our success is that our customer satisfaction rating, which is an unprecedented 97% for an ERP company. So we offer a comprehensive solution for healthcare providers for planning, finance, supply chain, and HR, built on the same technology foundation and delivered via the cloud. All of our customers are on the same version of Workday, and we deliver new updates regularly so customers can take advantage of continuous innovation. So enough about Workday. As we work with our customers and prospective customers in healthcare, they really are noting how the constant change within healthcare really keeps the strategy of merging, acquiring, or partnering with other organizations top of mind, really impacts decision-making, including things around their technology selection as well. In fact, most surveys show the volume of M&A activity is still strong, with the number of deals similar from year to year. And many systems are even looking at buying or merging as a preferred growth strategy in the year ahead. And of course, those activities are taking many forms. It could be affiliations, partnerships, joint ventures, in addition to the traditional acquisitions, or it could be a partnership that then leads to a further acquisition. And of course, there's, as we've seen, there's numerous reasons, of course, for pursuing an M&A strategy. It could be to expand across the care continuum, to provide care in additional settings. Maybe it's more clinics, more alternatives for how to deliver care. Or it could be to serve a broader population in support of a transition of population health. Or it could be to develop new capabilities and new offerings that the organization didn't have before. But in almost all cases, healthcare systems are looking to gain operational efficiencies through additional scale or standardization, including in technology areas like clinical or ERP systems. So as we, we'll take the next 35 minutes or so to speak with our panelists about their experience in the area of M&A, how they approach evaluating mergers, acquisitions, and partnerships, how technology can play a role in both the strategy and the execution, and then they'll share some of their overall lessons learned in terms of considering M&A or executing on M&A or partnerships. And then, as mentioned at the end, we'll plan on leaving some time for some Q&A to the panelists. So let's start by learning a little bit more about our panelists and your organizations, and we'll start with Mike. Mike, can you tell us a little bit about your organization and the industry drivers that are impacting your overall strategy, and then how you might consider M&A as a strategic option?
Okay, so NYU Langone Health is
basically an academic medical center, which has formed into a health system. So now we're NYU Langone Health. We have multiple locations throughout Manhattan, as well as the boroughs of Brooklyn and now Nassau County, which are affiliated or merged within our organization. We have over 3,000 physicians, either affiliated or employed within our FGP. We have about 600 medical school students in a medical school. We have over 1,200 residents that are in training. We provide faculty support and clinical care at the Bellevue Medical Center for New York Health and Hospitals Corporation, along with the VA. We're about an $8 billion organization. At least that's the budget for next year. We have traditionally been a fairly profitable organization. Had operating margin of 12% in the hospital up through 2012. Then, of course, became very adept at experiencing how to recover from a storm, because we had Hurricane Sandy that ended up wiping us out. People might have seen it on the news, and we were closed for 3 months. But then we quickly recovered and then came back. So right now we're running somewhere between 8 and 9% operating margin, depending on the month at the hospital corporation, and have a very large research operation of over $325 million of research grants, as well as $1.5 billion of physician revenue activity in the medical school. So pretty robust operation, one of the top ranked medical schools in the United States, and have really pushed an M&A activity which was focused on first physicians, acquiring physicians, and then once we had enough cadre of physicians in certain areas, then expanding into the acute care hospital market and finding a hospital partner that we could partner with. And in some cases we'd merge, and in some cases we'd affiliate in those markets, which is the strategy we've been employing.
And Robin, do you want to tell us a little bit about your organization, some of the industry drivers? I know you had a little bit of a different perspective from your organization. Can you share more about your organization and sort of your strategy and how you think about M&A?
Absolutely. Thank you, Keith. So I'm Robin Norman. I'm the Senior Vice President and Chief Financial Officer at Virginia Hospital Center. Our system is a one hospital system, 394-bed tertiary care facility located in Northern Virginia, so a suburb of Washington, D.C. Our market is dominated on the Virginia side by one player, although there's a number of other hospitals around. They're all affiliated with big systems. So when I look at us, either in the metropolitan Washington area, or if you look more broadly throughout the state, we are one of the very few left that are an independent. We're often referred to as fiercely independent, but our history was such that we went through an M&A with what was then Columbia HCA back in the late 90s. And that had, I lived through that. I was with the organization then in a different role. I actually became CFO in the middle of it. And then we broke apart. So I have a lot of stories from that and a lot of learnings. In terms of today, as I said, we are sort of fiercely independent, but it doesn't mean we don't look to partner. We partner in a variety of ways. One of our biggest partnerships is with Kaiser Permanente. They have a big presence in the metropolitan Washington area market. However, they don't have their own hospitals, so they partner with hospitals, and we are their lead partner in Northern Virginia. They do that because it's a tough area in that there's 3 different jurisdictions, Maryland, Virginia, D.C., all of which have their own rules and regs regarding opening hospitals, and to get the proper coverage, both from a traffic perspective as well as a distance perspective, you need to have more than one location. You need to have multiple hospitals, which can be challenging if you're Kaiser. So to date, they have chosen to work with partners, and we, as I mentioned, are their prime partner. And maybe the best example we have of partnering with others as a way to remain a standalone. We also have been fortunate to have good margins. We're in a good demographic area. They are part of Northern Virginia we are in. Northern Virginia in general has good demographics. Northern Virginia in Arlington County, which is the closest in county in Virginia to DC, is blessed with very strong demographics, which certainly helps us. What doesn't help us is by having sort of big systems all around us, we are a little more of a price taker than a price maker in terms of how we fare in managed care arrangements. At the same time, they don't particularly want us to go away, so we do also get some drafting effect, if you will, in terms of rates. So we've been able to be successful as independent. We see paths to remain that way, and so don't have current M&A plans, but have a number of plans in looking at ways to partner. I started to talk about our margins. We're probably in the 6 to 8% range for our margins the last couple of years. We're in the middle of a complete IT replacement. So for this year and next, I expect those margins to fall as we spend money on that project, but then hopefully recover after that. So it's kind of an overview of who we are.
Okay, great. And so, Robin, could you then just elaborate a little bit in terms of as your organization's overall strategy and what you look for in partnering with an organization, given that you're looking to stay independent? Well, what are how does your overall strategy sort of impact in the criteria you're looking for a partnership, and how you go about considering that?
Sure. I think one advantage of being smaller is we're able to take advantage of opportunities as they come our way. And the way we think about it strategically is ways to increase our footprint and our services without necessarily putting in all of the capital. So that is a lot of what we look at. We've looked at partnerships, for example, in radiology centers, in physical therapy centers, in freestanding emergency. We haven't done all of these, but we've been looking and exploring and are in the process of doing a couple of projects. So I think a lot of the strategy is simply how do we get out there more without trying to put dollars into every single thing or put all of the dollars into every single potential way we could expand our footprint. Most of what we currently have that's 100% owned is on campus. We have about 120 employed physicians. Many of them are specialists that are on campus, but we do have 5 satellite location physician offices. So that we've expanded directly that way, but indirectly by partnering, including with some other systems on, for example, home health, which was an interesting experiment that didn't ultimately work, but it was an attempt to go down one of those paths.
And so it sounds like you, rather than acquiring some of those services, you're looking to partner to really expand what you're able to offer.
Exactly. And where we're able to offer it in, I guess I'll call it watershed areas in between our market and our competitors' markets. We overlap dramatically. This is it's a tight-end suburban, quasi-urban community. So there's a lot of overlap, but the goal is to get our name known a little further than it is now, and therefore draw in hopefully more patients from those areas.
Great, thanks. So, Mike, just to kind of follow up on a similar question. So, as you look at the strategy of your organization, you were telling me a bit about how you kind of look at evaluating potential acquisitions or new markets to expand into. Can you speak a bit about sort of the criteria and the evaluation you go through in deciding that?
Well, I think you have to have an appreciation of how hyper-competitive this New York City market is. There's probably 5 very large major academic medical centers within 5 miles north of this campus, between New York Hospital and all that is done between Memorial Sloan Kettering and Hospital for Special Surgery, from New York Presbyterian, from Mount Sinai Health System up into Montefiore, and then you have, if you go east, you have Northwell out in Long Island. So very large competitors. So what we tend to do is, our strategy has always been a physician strategy first, where we look for physicians to affiliate with or join our faculty group practice plan. Once we get enough of a critical mass of physicians in a market, if we find that it's, say, more than 35 miles away, and we need a hospital beachhead to provide ambulatory care, because a lot of the care that we provide is ambulatory in the health system. Over 50% is ambulatory. So what we do is then we look first for big box ambulatory to be located with those doctors, and then if they ultimately need acute care, then we look for the institution that's in that market where most of them prefer, and try to affiliate with that hospital, which is why we came up with Lutheran Medical Center in Brooklyn and Winthrop University Hospital in Mineola, Long Island. We have looked at others in markets where we were just talking to them about their interest to affiliate with us, but those did not necessarily work, because we either didn't have the critical mass or referral base that was big enough to justify the entry into that market. But that can change, obviously, as the composition of physician changes and the healthcare marketplace changes. But that's where we are now. And then, as we expand and continue to expand the physician complement and the physician network, then we'll look to continue to expand ambulatory operations and other operations as needed.
So what are some of the biggest challenges that you face when implementing or executing on an acquisition plan?
So for us, we've decided that our plan is to integrate people within our systems, our financial systems, as well as our clinical systems. So we've built our entire IT infrastructure around two big platforms. There's the PeopleSoft Oracle platform that we have for ERP. And then there's the Epic platform for clinical information as well as billing. And then we integrate the two with the EPSI decision support product. So we want everything to be seamlessly integrated into those two big platforms when we affiliate with someone. If it doesn't, we either replace it all out, like we did in the case of Lutheran when we took them on, and just within a year we had that all replaced. Or in the case of Winthrop, we're now in the process of evaluating how to transition and merge some of that data together, so at least we can get consolidated financial statements till ultimately we get to the point where they would, convert into our platform. So that's a big key, that when we go with people, we're trying to get the sameness of the platform, integration of the clinical data, so you can do good population management, risk-based contracting, those types of things.
And Robin, I think when we were talking earlier, you mentioned that you kind of went through an experience where a merger didn't quite work out. What were some of the challenges that activity faced? And just could you share some of the challenges that you had with that?
Sure. Yeah, we had, I'll talk about the main one, but I sort of have two examples of that. The first was back in the late 90s, where we went into the joint venture with HCA. And it was one of the joint ventures they did at the time that was a 50-50 ownership. I think the biggest challenges in it, one were culture. It was a tough culture fit for an organization that had been a nonprofit for its whole history, and sort of joining in both technically abandoning everything we had and going with different systems. But I think just people and culture-wise, and finally being a 50-50 joint venture was extremely challenging, because, how do you settle things? And there were a number of reserve powers that could only be settled by a majority, which was quite challenging. So those those were some of the problems in terms of the times. The other thing that happened was we went into it with the strategy that, gee, as a standalone, everybody around us was starting to affiliate. Insurance companies were developing products that were forcing people to, which system are you going to go with almost. There's a little deja vu going on today in the market, but at the time it was clear that a number of the health payers were going to go into exclusive type arrangements. Now, it didn't pan out in our market at that time. The market wasn't ready for it. And in the couple years that we were in the joint venture, two things occurred. One was that those exclusive type arrangements did not take off, so we didn't feel as threatened. And then secondly, there were tax reasons. We had, one of my colleagues had the IRS in his office more or less for 2 years, looking at whether this was, appropriate and could the portion of us that stayed nonprofit still act that way. And anyway, at the end of the day, one of the agreements when we went into it was if we didn't have a clear ruling after 2 years, we had the option to back out of the agreement, and sort of we all took the toys that we put in and go home. And that's exactly what ultimately happened. So the reason that we broke it up was the tax reason. However, there were a lot of changes in the market and bad culture fit and other problems with the 50-50 joint venture that made the decision perhaps a little easier to go on our own. Yeah, I'll give one other example, though, of something that we've been trying to do for a while. I mentioned in our market there is one large system. It's the Inova Health system in Northern Virginia. But in addition, the other large players have single sites or maybe 2 sites within our market, but aren't anywhere near as much as a dominant player. So Centara Health System, a very large player elsewhere in the state of Virginia, has a hospital. Novant, which is primarily in the Carolinas, but has one facility here in Northern Virginia. So, we look at ways where we can partner with them to be the not Inova when we talk to insurance plans or physicians, and looked at some sort of a clinically integrated network, which made all the sense in the world, but trying to get buy-in and approval from different organizations with different goals and priorities has proved darn near impossible to date. They do it there, everyone has their way of doing things. We've had a variety of approaches working with insurers. There is one insurer who's sort of doing it on their own without a full integrated network, just seeing that that's a potential that we are, all of us are a potential better network together than just having Inova as the standalone. And but anyway, the problems with it have been that it's separate organizations with separate goals, and that's made it very challenging to get where we'd like to be.
Okay. Great. So let's move on to just talking a little bit about technology considerations. And I think we often hear from our customers and prospective customers about how technology can be a key enabler of success as well as a driver of operational efficiency when looking at mergers and acquisitions. And I think, Robin, in your example right there, you were kind of also talking about where you might need to be able to share information across different entities as well. So I'll start with you, Robin, then I'll go to Mike on this. But as you're thinking about either partnerships or your strategy, what role does technology play in that, in your evaluation and process, either upfront or in executing on these things?
Yeah, the way I'll approach the question is that I think I mentioned earlier, we're about to put in a new health information system. And when we were searching for which system to use last summer, we definitely took into consideration the fit to the other players in our market. So there's a couple of big players in the healthcare space that do full hospital and healthcare information systems. And we looked at who was dominant in this area, both for partnership potential for, in this area, meaning Northern Virginia, meaning our region. So knowing that, although we're fiercely independent, we don't have our head in the sand. We may have ways to partner, or we may even wind up in some kind of full partnership with one of the other major players in the area. So we tried to look at that as a factor in making the decision with where we ultimately went. So I think, technology is a big part of it. When we went into and out of the HCA venture, we had to completely switch technology twice within a 4-year period. So hopefully you all are out there feeling my pain. That's not a lot of fun to go through that much change that quickly. But I think that it definitely was a factor in how we approached the choice of the system to know who our partners could be. And, it's always could be, so things could change, and who knows, we could have made a choice that ultimately won't serve us. But we think that we made a good choice for lots of reasons, but it also fit this. So that's how technology played into our thinking.
Great. And Mike, I think you already alluded to the fact that you take the strategy of trying to move everyone to a common set of clinical and ERP, financials, and HR solutions. Right. So can you just speak about how technology plays into your plan and your process?
Well, that's how we do it when we are doing the basic merging of or affiliating with the larger hospitals that are going to join the network, because we're up to say 4 or 5 hospital sites that are in the network. But the one thing that we also try to do is when we affiliate with other non-hospital providers, and we're trying to get them to share clinical information, we're using an Optum platform to help do some of that population health and integrate some of that information from the RIO, that exchange-based electronic depository of medical information that then we use. So we have a district experiment in the state, and we're managing the Medicaid lives. We probably have 127,000 or roughly lives that we're managing today in this district network, mostly Medicaid. And so we have everybody sharing data through this network so we can try to manage the population well and get the bonuses that are available under the program. And so we try to build some interfaces, and then we've built a technological platform with Optum that allows us to try to manage those patients from a pop health perspective. So I think that's helped a little bit in allowing people who aren't part of either the Epic platform or one of the other major ERPs, but do have a lot of patients that they can come in and share the data and look at how their lives are being managed and help manage them in a more efficient way according to the goals of the district experiment we have.
And so then as you start looking at technology investments, whether it's for financial systems or clinical systems, or just has now this M&A activities, has that changed how you evaluate and look at technology investments? Are certain criteria more important?
I think it's made it very clear that we believe we've chosen the right strategy to have everything tied in to those 2 pillars, which we built the health systems IT infrastructure on. So if it doesn't interface seamlessly into those 2 pillars, then we don't buy that, and we get people either, if they're affiliating with us, to change platforms, or then they're going to have to just deal with us on an affiliate basis. They're not going to be able to merge in. So that's basically what we've done doing. So we have teaching affiliates with some hospitals where we provide faculty, to go out there and teach, and sometimes provide clinical services. But in those situations, we're not the integrator, right? Or we aren't even managing population, just providing a service. So, and in many cases, those are networks, say in New Jersey or in northern Westchester County, which really didn't have the ability to move, merge with us and move onto our Epic platform, didn't have the ability or the wherewithal, the need to. So therefore, we didn't, go into that full asset merger in those markets.
Okay. And then, Robin, just in terms of then your experience of a couple of different situations, how has that changed in terms of how you evaluate technology investments? What criteria are you looking at as you're looking at investing in systems?
I think the ability for systems to talk to each other. So we're never going to pick a system that's going to clearly it's going to be the same as the rest of the world. So unless the government totally takes over healthcare and puts the same system everywhere. So having said that, I think how well they are able to communicate with other platforms is a key consideration, just to make sure that we have that opportunity, no matter what partner we may pick in a service line or even ultimately a full partner, that we would have the ability to do so. Because I do believe that data integration, as Mike said, is critical.
So is there any lessons that you've learned or recommendations that you'd advise others to consider?
I think that, as I mentioned, the culture of the organizations that you either partner with or merge with is going to go so far towards success or not success. And I saw it play out personally. I've seen it in talking to others. I think that's the number one thing. I think the synergies that are otherwise there in terms of, what's your goals going into this? So having a clear idea of what you want. Are you trying to get cost reduction strategies? Are you trying to expand your footprint? Making sure that you're not just sort of taking the next thing that walks in your door, but that it fits with that strategy. So those are the couple that come to mind that I think are just critical to being successful.
And Mike, is there anything else you'd want to add just in terms of managing information and data within your system besides sort of the standardizing? Do you have other recommendations you would make?
Well, I think you have to build a critical role of care managers and people that are going to do the data mining assessment. We have a whole academic group, which is a Department of Population Health, that does a lot of studies, whether it's health disparities or things like that, with the data that's available in our systems from the multiple different markets, which are pretty disparate socioeconomically. So we've been able to use those capabilities to manage the lives, as well as then do the assessment of the data and do the research and then publish results. So I think if you have to have that built first in order to really make the use of the wealth of data that you have out there that can be generated from these systems. One of the things we've also been able to do is, because we have both inpatient and outpatient data on all the patients in the network, we've been able to use that to find the missing information that's preventing us from maximizing our reimbursement with payers. So we can improve our data capture and data entry, and at that same time in our documentation, and then we're able to code it. And then once we can code it, we can charge for it. After we charge for it, we can bill for it and then get paid for it, and then make sure we get paid the maximum amount. So we've been recovering. I think last month we recovered $14 million just in a month from all of these zero balance accounts that otherwise we would have been writing off and adjudicating. And instead now we're recovering additional money. So I think that's been the difference between, having a 1 or 2% margin and having an 8 to 10% margin. And so that's one of the things we've been able to do by having this wealth of data and being able to then take that data, query physicians and say, based on what we see in the data and from the medications the patients on, we believe that they have these diagnosed conditions. Could you then check and put that in the chart? And if they put it in the chart, then you can code it, and then you can charge for it and get paid for it.
Okay. So it's not just having the right technology, but it's also having then the roles that are
it's what you
take
do.
advantage of.
I mean, technology is just a tool. It's what do you do with that tool, right?
Great. All right. Well, let's move on to the last set of questions, and really to talk a bit about some of the lessons you have learned throughout your career. So, Mike, this is starting with you. Just in looking back, what were the keys to successful integration? What things have worked and what didn't?
Okay, well, I've been around the block a number of years, and I've seen a lot of these merger opportunities fail, and I've been parts of ones that have succeeded. And I think in many cases, what you have to understand is when you're putting these two organizations together, you have to understand the reason for the merger. You have to understand the disparity or the synergy of the cultures, and you have to figure out how you then become a system, and what are the roadblocks preventing you from becoming a system and then acting accordingly. And I think in many cases, when you can't get the people to agree that they're going to be a system and they're going to have some standardization, that's when you ultimately have, or you have a culture clash. That's where you ultimately have the failures. And so in a lot of these cases, I think when you're doing your assessment, you have to be willing at any point in time to walk away, because I think there's nothing worse than having a bad merger, because then to unwind that, it takes a lot of pain and effort and cost that you otherwise would have been able to avoid if you did the right assessment ahead of time and avoided that. Right, so you got to be willing to walk away when you're coming into these, so eyes wide open, and be able to walk away when you know it's not going to work out.
Okay, great. That's good. Great insight there. And Rob, and just the same question as you're looking back, what are the keys to successful integration? What worked and what didn't? And I think again, you have that perspective of an integration that didn't work. So it'd be great to just hear kind of what some of your key keys to making a M&A work.
I think that something I haven't talked about is that there has to be a clear person in charge. I don't mean just person, but entity that's in charge. So I mentioned now the 50-50 joint venture made it extremely difficult to move forward, to put plans in place, too many conflicting ideas and thoughts. And that went along with the lack of a culture fit. So I think that for us, and now more current information, just in terms of partnerships, we also, maybe it's our size, but we don't feel like we always have to be in charge. If there's someone who is great at putting out radiology centers and would like some of our backing and our name, then, let's get together and make that work. And if they have the majority, fine. So we're not hung up on being the majority, but I think we've learned the lesson of trying to make it 50-50. It just doesn't work. So I think someone has to be more clearly in charge, so that, and again, you have to have those goals in advance. You have to understand how it's all going to play and then make it play out. I think in today's world, a match of technology makes it more efficient, effective, and easier. I don't think it's the critical deciding factor, but I think it's certainly one. And I've probably said culture too many times, but I can't overemphasize that. I just think it's one of the most important things as to whether it's going to work or not, because if the cultures are good and fit together, good people will find ways to make it work and get around the issues. If they're not, it'll just become messy and fail.
Great. And so just to wrap up the questions, well, what final piece of advice would you give those who are considering M&A and partnerships? And Robin, if you want to start.
Sure. I've said culture enough, but that's certainly number one. Number two, I think, is think about going in how the combined organization is going to be greater than the sum of the parts. And then, in turn, the third thing is execute that plan. So if one of the ways that it's better is you're going to save money because you're going to combine whatever, legal, billing, accounting, maybe even services into, one site. If that was the game plan and that was a lot of the logic and reason for getting together, you've got to execute that plan and execute it effectively and as quickly as is reasonable to see the benefit. Because you can easily lose momentum, and if you're just saying separate organizations, but now you're together, that doesn't, I don't think, get to what anybody's goals were. So I think those would be my parting thoughts.
Yeah, I kind of parrot some of that. I think what we found was when you first come in, you have to have an assessment of what are the synergies and what are the benefits that can be derived from either the affiliation or the partnership or the full asset merger, and then come up with a plan over the short term and long term of how you'll achieve that. And then you have to be diligent in executing that plan and making sure that you remove the barriers from achieving the results that you all agreed to in that initial planning phase. So you have to have a buy-in from all the parties on both of the sites or all the locations that you're bringing into the arrangement. And then, really almost have a ruthless execution of that plan and make sure that you achieve those results, and then have a measurement methodology to make sure you're achieving the results as expected, and if not, why not?
Great. So, I mean, this has been great just to hear your experiences and your insight. So really appreciate you participating on this panel. Let's go ahead and open it up to questions from the audience. Emma, do you want to give an update on how to enter questions?
Fantastic. Thank you so much, Keith, Michael, and Robin. For the audience question and answer session today, you can submit any questions that you have by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. And we'll try to get through as many questions as we have time for today. There have already been some great questions already entered in, so thank you. And we'll get started with this first question here. The question is for Michael and Robin, and asks, as you expand your footprint, either with mergers and acquisitions or partnerships, how do you manage the volume of physician orders coming into the organization, juggling where to send the orders, specifically preventing duplicate orders or missed orders, as a patient may visit more than one physician in the area?
This is Robin. It's a great question. I'm afraid the technology is not my forte, so I'm not sure I can answer that well for you. Making sure that we aren't duplicating patients, because we have that to some degree now. We certainly get referrals from physicians that are not on our staff for a variety of tests and other things. But I'm sorry, I'm not going to be able to be much help on that one.
I think that's one of the reasons why we try to integrate everybody onto the Epic platform, so that data would be available, it would be seamlessly accessed, and then you would avoid the duplication of tests that were ordered and had results in one area, and then you send the patient, and if you don't have access to the results, then you order it again. But I think they tried to have that available via these RIOs that are out there, but a lot of the data was just faxed images, so it really wasn't data. So in many cases, unfortunately, if you're sending a patient multiple miles and somebody needs an exam and the results of that exam in order to validate the diagnosis that they're making, whether it's an image or lab work, it's going to be ordered again.
Yeah, this whole point is one of the reasons we went out and looked for a different system, because even within our own system, our physician practices and employed physician group were not on the same system as the hospital, and we faced this very problem even in that limited group. So I think that we're going again to a system that's more common in the area, and we will certainly open it up to physicians to be able to order through there as a way to help this problem.
Fantastic. Thank you both so much for answering that one for us. The next question from the audience is interested to know your thoughts on the following. If one universal payer is the healthcare future, what impact do you think this will have on mergers and acquisitions?
Go to Canada. You'll find out very quickly what it's like.
Yeah, it's a scary thought. But if it went down that path, yeah, you have to wonder, if you got a universal payer, why you don't wind up with a universal owner. I used to think that this industry was going to be like banks, and eventually there'd be the bank and the healthcare system. That's not an impossible future. I don't think anymore that it's a likely one. As I've matured and watched over time, there is still a lot of locality to what's provided. So I don't know. It's well, you ask theoretical questions, I guess you get theoretical answers. I think it would probably increase the likelihood, although some of the goals behind a universal payer, or some of the goals, you no longer have access worries the way you do today. So as I mentioned, we're the smaller players. So is there going to be an exclusive network that leaves us out? With a universal payer, that's probably less likely. So that's one side of it. On the other hand, if the universal payer pays us like Medicare or even worse, Medicaid, then the cost pressures would be such that it would increase the likelihood. So I guess it depends is my best answer.
Every state that has tried to have a single payer system has ended up backing away and having that system fail. So even Vermont. So it's not something that I see that would happen in this country, especially with everyone wanting to get health care that they buy from the commercial insurance market, and they want differentiated health care from what they would have to receive if, for example, they had Medicare or Medicaid only. And so I think it's not something that I would see in the future. But if we did go to a single payer, I think there's going to be enough differentiation for the commercial care that you would access above and beyond that, so that there's going to be some need for more like private hospitals, which cater to those people who are willing to pay a little bit more for the health care and then offer that stuff that's not covered by the basic plan that you have. I would hope that we wouldn't have like public hospitals proliferate again all across the country, and then you'd have a tiered system of care. So the public system gets one level of care, and then people who have commercial insurance get a different level of care.
Fantastic. Well, appreciate your candid responses to that question. Moving on, Robin, I know that you discussed the importance of culture when partnering with other organizations. So perhaps you can tackle this question first, and then Michael, would love to get your input as well. So this audience member asked, when acquisitions are agreed to, there are people within the organization that don't have the buy-in that is desired. How do you create this buy-in, and how does that help the new culture develop?
I think that some of the best ways are, to the degree you can, keep people informed. The first thing they want to know is, what does it mean to me? How does my job change? Do I have a job? Sort of all of those questions that come up first. So to the degree, I'm a big believer in general in transparency. So, keep them informed, and also, just as important, tell them the why. So why are we doing this? What's driving this decision? Because I think that telling them the why is a lot of how you get buy-in, because they can understand it and accept it. I think you also have to not be afraid for those that just, first of all, for those that won't have a role in a new organization, to have that happen quickly and get it behind you, so that everyone else isn't wondering. And then maybe on the more positive note, for those that are staying with the organization, if there's some that just won't come along, don't agree with the why, et cetera, then you just may have to move them out of the organization. And that's, I think what I mean by culture fit is if everyone is sort of on the same page, understands the why, understands what the goals of the organization should be combined, then you've got the right group and they'll work well together.
Right. For us, we always are looking for the people that are advocates of this, of achieving the synergies that you originally put forward when you did the affiliation or merger. And then those are the people that become your champions, and then they become the sales force to help sell the need to go forward with the plan to achieve the synergies. And then you quickly see who are the naysayers or the people that are putting up roadblocks for achieving that. And those are the people that you have to quickly isolate and then move out of the organization if they're really preventing progress that has significant either economic or clinical advantage, because at the end of the day, you want to put the patients at the center of everything you do, and you're always going to try to act in their best interest and do what's best for the patients. And it's not about the individuals who are working at the institution, but it's about the patients that the institution is treating. And so that's really what you're trying to get everybody to focus on, and then you want to act accordingly when you implement your strategy.
Fantastic. Thank you again for those great answers. The next question that we have here says that how do you set realistic expectations of when financials and medical records and systems, et cetera, can be fully integrated? It's oftentimes that people expect maybe quicker results than what is doable. Would you all be able to comment on that question?
Michael, go ahead. You've had more experience with that.
Could you basically reset, because I'm not, what was the question in there?
Sure. The question is, how do you set realistic expectations of when financials, medical records, and systems, et cetera, can be fully integrated?
Well, I think it's based on the track record of how you could go through a conversion. So depending on where they are and what's being replaced and how big the organization is, that's how long it'll take. So normally it takes, for a fully integrated billing and clinical record system, it's going to take 9 to 12 months to get that installed. And I don't see anybody who does it in much sooner than that. And for a full ERP, again, it's going to take something like that. And I don't think you can do all of it at once. So it's probably going to have to be in a staged fashion. So I think when we did it, we first put in the foundation of the platform, which is the ERP, and then quickly after that, then that's when we put in the Epic, the Epic transaction. So it pretty much was done within 9 to 12 months. Some of the stuff being done concurrently, but it was pretty tough, but it was doable, but it was very expensive.
This is Keith. Oh, go ahead, Robin.
I was just going to say, I'll just make the broad comment that I think for setting expectations in general is going in is always a good idea, whether it's around the technology or it's around any of the other potential changes that may occur. And a lot of that, I think you have to do well up front to make sure this transaction makes sense and is a good transaction to make, as well as just understanding the financial future of the combined entity. So I think that a lot of the things that go into making the decision and that are presented to the governing bodies of the respective boards should help set those expectations right up front.
So this is Keith. What I would add is that, and the question sort of speaks to the fact that there are higher expectations now in terms of being able to bring together data from multiple systems and make that available to the organization. So that's where, when selecting technology, looking at including that as part of the criteria and evaluation, and we're certainly seeing that more and more, that it's a consideration and expectation of how am I going to connect my financial supply chain system with my clinical system, what analytics am I going to get out of that? So have that as a criteria, but also then during implementations and project teams, making sure that the teams that are responsible for clinical systems and financial systems are are talking together and designing it together, and the analytics team are involved. So it's something that's part of the implementation. I think most organizations sort of recognizing that going forward, where traditionally it might have been a siloed project.
Fantastic. Thank you, Keith, Robin, and Michael, for weighing in there. Keith, we have had a couple questions specifically regarding Workday. And quickly, is there a good place for those folks to follow up regarding specific questions about Workday platform?
Yeah, so, we could have them follow up. We can reach out to them, and we'll have with an email to get more details. I would recommend, of course, going to Workday.com, and we have a section on healthcare as well, which just gives an overview of our platform or solution, our specific capabilities for healthcare providers as well.
Great, fantastic. Thank you so much. And it looks like we'll have time for just perhaps one more question today. Again, we do appreciate all the questions that have been submitted for the webinar this afternoon. This question states, what are the impacts to mergers and acquisitions as healthcare moves towards 1, value-based care, and 2, appropriate modalities like urgent care and care managers and PCPs?
Well, I think a lot of it is going towards the fact that if you don't have the technologies available or the ability to invest in those technologies to manage lives, then you run the risk of being left behind when others in your marketplace are coming up with risk-based arrangements with the payers to manage those lives, and then they end up shutting you out of their networks. I mean, if you think back about how bundled payments were implemented by Medicare, and what a lot of people did is they found out that if you were discharging people from your acute institution to a long-term care facility, that they tended to have much higher costs than if you sent them either home directly or sent them home with home care. And so what happened was all of the long-term care facilities ended up getting cut out of the bundles very quickly. And so I think, that's the risk you run if you don't have these technologies and you're not willing to take this risk-based arrangement with the payers. And then ultimately Medicare and Medicaid will be trying to put a lot of their populations on some type of risk basis. And so if you're not in a big network that can afford the IT infrastructure to manage that, you're going to have to merge into an operation that does provide that. Otherwise, you have the risk of being shut out.
Yeah, I think that's fair. I think that there has to be, depending on how good technologies get at being able to talk across platforms, I think it'd be much easier if you're part of something larger. I don't think it's impossible, though, to still be alone and be a portion. You may not be the controlling interest in that risk contract, but you can be a portion of it. And if you can provide what you do well, cheaper and with higher quality than the other guy. And our best example of that is working with Kaiser Permanente. They saw us in the market and others as a better alternative because we had high quality care. But they're the ones aggregating the data and ultimately obtaining the lives. So if you're comfortable in that kind of role, that's how it could work.
Wonderful. Well, on that note, we're going to wrap things up for the webinar today. I just wanted to say thank you again to Michael and Robin and Keith from Workday for their excellent presentation, and to our audience for participating today. We hope that you enjoy the rest of your day, and we look forward to having you join us for future webinars. Thanks again.